Okay, hello everybody and welcome to today's webinar on chronic disease management and making the most out of the Medicare items. My name's Gay Nuttall and I'm on staff here at Rural Health West. And obviously on the slide you've got in your screen at the moment is our introduction and housekeeping. Obviously you're very welcome to type your questions through and I'll do my best to keep an eye on that and answer as we go. Otherwise, I'm very, very happy for you to email Sonia here afterwards and we'll respond to you individually. So, as I said, my name's Gay and I'm a registered nurse and I've worked in the area of GP and general practice education for about the last 10 years, and one of my favourite topics is Medicare items and particularly the chronic disease management ones. And I regularly do sessions like this. Obviously it's a little different on a webinar because I can't see you all, but hopefully you can hear me and see the screen. And if there's any issues, please just send a question through to let us know. Now we have had some rather nasty weather here in Perth today and we've had a few dips in our power. So we are a little nervous that we're suddenly going to drop out. If we do, you'll have to just blame the weather. But hopefully we will be okay. So of course I probably do need to just say that I'm not Medicare or representing Medicare, but I was lucky enough a few years ago to spend quite a bit of time working with the medical advisor at Medicare at the time, who was very good at answering questions and working with general practitioners and trying to make things a little easier to understand. So I've got a reasonably good idea of what Medicare's intentions are and what they mean by some of their wording. As we know, sometimes it's a little bit grey and a little hard to interpret. So hopefully by the end of today's session, it will be a little clearer for you, and we'll see how we go. Okay, so you all know the Medicare benefits schedule well. So what is a chronic disease, which is what we need to start with. So according to the Medicare benefits schedule, a chronic disease is any medical condition that is present or is likely to be present for 6 months or more, or is terminal, which is reasonably straightforward. There is no set list of chronic diseases. So I often get asked that, is there a list we can go to? And the answer from Medicare is no. But of course, you're all aware of your standard chronic conditions, diabetes, asthma, cancer, cardiovascular disease, musculoskeletal conditions, stroke, any of those. But basically, any chronic condition that is, likely to be present for 6 months or more is considered to be acceptable. This table that you're looking at now is just showing an overview of the main items. Now I'm going to be going through the nitty-gritties of each of those items, and when we've gone through the main items, I'll then also be focusing a lot more on the allied health rebatable referrals that you can do, which is the ones that tend to generate the most questions. So I will be talking, in much more depth about those. This slide that you're looking at now is showing you the number and the recommended frequency, and then you'll see on the last column it's got the minimum claim period. That is the recommended minimum claim period from Medicare. If you do, for example, a GPMP at the 13-month point, you don't need to give an explanation to Medicare as to why you're doing it. If, however, you wish to claim one of these items in less than the minimum claim period, then you do need to be putting an explanation into your billing text box to say why you've done it. And I will talk a little bit more about that. That slide there is a fairly busy slide, and hopefully you can see it quite clearly on your screen. it is quite a good one in that it's showing you the numbers, how much the fee is currently, what the minimum claim period time is, and then who is the ones that are, involved in it. So as you can see on the last column, it's got a practice nurse or Aboriginal health worker may assist with a tick in every column to show that, that's allowed under the rule. So that is quite a good chart for you to have a look at in more depth when you need to. So we'll start now with the first main item number, which is the GP management plan, GPMP it's usually called, which is the item 721, which is, the one that is used most, of course, and hopefully you're quite familiar with it. And as I said, that's for any patient with a chronic or terminal condition where you're looking at putting together a plan with a structured approach to manage that patient's condition. Now, GPs can do a GP management plan without having to collaborate with other providers. Even if you do have other providers involved in the care of the patient, you don't have to necessarily go on and do the team care arrangement. You may just choose to do GP management plans so that you've got a structured approach. The patient's got the copy of something that's useful for them. And in my experience, if it's written in a fairly clear and concise way, they can be a good tool to get the patients on board with what it is that you're trying to achieve with them. The other good thing that they can be used for is particularly your older patients who may be retired and travelling quite a lot. They're a good thing for those patients to take a copy with them. I'm sure for you guys out in rural areas, you would probably quite like some of those travellers who appear at your practice to have a little bit more information at hand. And of course it works, in the reverse. And it's also quite good to have a management plan for the carers because quite often people get a bit confused, don't really understand what you say, or they're trying to take in a lot when they're in with a visit with a GP, whereas if it's all in writing, it is, can make it much easier. So not only are we looking at it from the point of view of increasing revenue, but we are really wanting it to be a positive tool that will actually encourage the patient to meet the targets and the goals that you're setting for them to manage their chronic condition. Okay, so this slide is looking at the preparation of a plan, and this information is coming directly from the MBS. So this is saying to you what is the written content of that plan. Okay, so we're looking at the problems, the goals, the actions to be taken by the patient, the treatment, who's going to be providing that treatment, and how is the follow-up going to happen. And at the end of today's session, I'll be talking a little bit more about the templates and the different templates you can get for your software programs and which ones perhaps are easier to use than others, and making the most of those. Now, in preparing that plan, there are certain actions that are required by the GP, and these again are taken straight from the MBS. So we've got the fact that not only are you doing the written content, but you're also then making sure that you've explained to the patient what it is you've done, you've recorded it into the plan, you've got agreement from the patient, and you offer a copy to the patient and their carer if that's applicable, and certainly, of course, a copy into their medical records. So that's the basic overview of a GP management plan. Then we go on to the team care arrangements, the TCAs, which is item 723. And this is where it all starts to get a little bit more complex, not only from the point of view of what you need to do, but also from the fact that it applies to a patient that has complex care needs. So it's appropriate to do a team care arrangement for a patient who's got the chronic condition but is considered to be, according to Medicare wording, complex in their care. So they require ongoing care from a multidisciplinary team of at least 3 providers, of which one is you, the GP, okay, and requires collaboration between all the providers based on, as it says, two-way communication. And I will go on and talk much more about how that referral process needs to go and how you work better with allied health providers. If a patient has got the GP management plan and the team care arrangement in place, that then makes them eligible for the 5 rebatable allied health visits per year, which everybody I'm sure is quite familiar with. And then you'll see the last point on the slide where Aboriginal or Torres Strait Islander patients can also be eligible for further visits specific to the Closing the Gap initiative. If you're working a lot with Aboriginal patients and you want some more information about those items specifically, feel free to email Sonia, and Sonia and I will provide you with some more information on those. Just on a small point there on the two-way collaboration where we've got oral or written, it of course can be by email, but it is required to be through secure messaging because obviously you're dealing with confidential patient information. Okay, so we'll just talk a bit about the requirements of the team care arrangement before I go into more specifically the allied health components. So coordination, obviously you need at least 2 other providers. Of those 2 other providers, only one can be another medical practitioner, so for example another specialist. So if you're looking at doing the minimum number of providers, you've got yourself as a GP, you've got, you can have 1 specialist, but then you must have 1 other non-medical practitioner, so obviously an allied health practitioner. If you've got more than 2 other providers, then it's acceptable to have 2 specialists, if that makes sense. That can be a little bit confusing, that part of it. So we've got a minimum of 2 other providers, of which only 1 can be a specialist. However, if you have, for example, 2 allied health providers, you could then have 2 specialists. As you'll see on that final point on that slide, the patient's informal or family carer can be included in the plan, but you can't count them as one of the 3 minimum providers. If you've got at least 2 other providers, then you can certainly put them on and include them, but you can't count them as one of the minimum. Okay, so when we're coordinating the team care arrangement, it's the same as the GP management plan. You're required to be recording the treatment and the service goals, who's going to be providing that, what are the actions that the patient needs to be doing, and what's the follow-up process that goes with that. And all of that needs to be recorded on the team care arrangement part of the plan. This slide here is looking at what the GP must do as an action. Now, just to put in an aside here, when I'm talking and saying the GP must do this, it is quite acceptable to have a practice nurse or an Aboriginal health worker or another allied health practitioner who's working within the practice to be doing a lot of the components of these plans. It just needs to be noted that the GP does need to be seeing the patient before the billing actually happens. So you could have the bulk of the plan done by a practice nurse, for example, and then a review and a sign-off, particularly when it comes to the medications and how they're being managed, and the actual referral and pathology and those kind of things being done by the GP. So looking at that slide, these are the actions again that need to happen, where we're looking at making sure that the patient understands what's going to be happen, that you've spoken with the other providers and got agreement, and you understand what it is that they are going to be contributing to the care of the patient. Recording that the patient's agreed to have a team care arrangement put in place. Copies to the relevant providers and a copy in their records, obviously, and one offered to the patient. Okay, can a GPMP and a team care arrangement be claimed at the same time? Yes, it can. But of course, you need to know that you've actually met the basic requirements of both of them before you can claim. But it is acceptable to do them both on the same day. So, for example, if you're putting together the GPMP, that's pretty, reasonable because that's the GP care. So obviously you're in charge of that. That's okay. In order for you to bill the team care arrangement on the same day, you just need to know that you have had feedback and agreement from the other providers, a minimum of 2 of them, to say that yes, they're willing to see the patient or continue seeing the patient, and that you do know what it is that that provider is going to be doing for your patient. Now, the recommendation from Medicare is that when you're actually doing the billing, or your reception staff are doing the billing, they need to put the GPMP in first and then the TCA in second. Okay, this item we're looking at now is the review of the GP management plan and the team care arrangement. This is item 732. For those of you who have been around for a while, we used to have separate item numbers for a review of a GPMP or a review of a team care arrangement, and then a few years ago with the red tape review they consolidated these into one item number, but they apply to either or both. Okay, so item 732 is the review. Now, as you can see on the first dot point on this slide, Medicare have now put into their explanatory text that it can be conducted by any GP from the practice or a new GP if the patient has changed practices, whereas it used to say that it had to be the usual GP. So that is a bit of a change. It means now that if you're in a group practice and a patient, is moving across a couple of GPs depending on who's in and who's busy, it's acceptable. Obviously, you would want to have a policy within your own practice as to how you deal with that. But from a Medicare point of view, it doesn't have to be the same GP. So when you're reviewing the GP management plan, then obviously you're looking at the original document that you wrote, going through all of those items and documenting any changes. Now, if you're using electronic versions, which hopefully most of you are because it does make life easy, what you do is you go into the patient's documents, bring up the original GP management plan that you did, and then you can just add another column to the end to put some notes about what you've reviewed, or you can simply add to it within the columns that you've already done, but just date, put the date in, today's date, to say what it is that you're doing or what you've changed, or note that you're going to continue the same. And then at the end of it, you need to document that it's been updated and reviewed as today's date, and a copy of it to the patient. And then you save it as a new document, so you will be saving as the review document as at the date. Hopefully that makes sense. Now, if you're reviewing the team care arrangement as well, if you've got a team care arrangement in place, you can only bill for the review of the team care arrangement if you've had feedback since the previous, either the development of the team care arrangement or the previous review. You do need to have got feedback from a minimum of 2 providers in that period of time in order to be able to bill the team care arrangement. So you do need to just be a bit sure about that. You need to obviously look back through the patient's records to see whether they have attended the appointments that you referred them for. Have they seen the podiatrist? Have they seen the physio? Have they seen the endocrinologist? Whatever it was that they were referred to do since the plan was put together. Have they seen them in that interim period? Have you heard back from those providers? Was there any change to the treatment? And you need to be documenting all of those, again, before you can build the team care arrangement. If you're looking at the feedback and you've done the review of the GP component, it's perfectly fine to build a review. But if you discover really that actually the specialist appointment hasn't happened yet and it's not for another couple of months, and in the interim they've only seen a podiatrist, for example, then you can't build a review of the team care arrangement because you must have feedback from at least 2 providers. If you did a team care arrangement in the first instance that had, for example, 4 providers, as long as you've got feedback from 2 of them, you can legitimately claim the review of the TCA. So I hope that that's clear. And again, when you do the billing for the review of the 732, if you're doing it twice on the same day, it's a good idea to notate in the billing that it was, one was the review of the 721 and the other one was the review of the 723, just to make it clear to Medicare that you've not just made a mistake and billed the same item twice. Okay, I've probably covered off on most of this, but when you're reviewing, as I said, both of those things, you are required to make sure that you've gone through, documented, given copies, added copies, the same as what you did in the first instance. Moving on now through the list of the item numbers that are applicable to chronic disease management, this is item 729, which is one that you may not have used ever before and may not even really be aware of. This is where you're contributing to or reviewing a multidisciplinary care plan that's been prepared by another provider. And to be honest, it isn't used very much because for most instances, as the GP, you would be wanting to probably do your own plan and do a GP management plan regardless of whether the patient has got a care plan put together by somebody else. But for those of you, there might be the occasion. One example that I could give you is, for example, with Silver Chain. If you've got Silver Chain involved in the care of your patient at home, they will have a fairly good care plan generally that's been put together, that's kept with the patient or kept at home, and you may be asked to, contribute or add anything to that plan. That's when you can use this item number, but again, it's not used very commonly. The next one, however, is one that is worth knowing about. So for those of you who are involved in looking after patients in a residential aged care facility, or for those patients that are in a multi-purpose site which have the appropriate recognition from Medicare, then you can use the item 731, which is your contribution to the facility's care plan. So you don't have to be writing the whole plan. Now, all residents in an aged care facility under the Commonwealth requirements, those facilities do have to have quite extensive care plans. I'm sure you're very familiar with them if you are visiting facilities. So what you're required to do under this item number is obviously review the plan and then add the medical component to that plan, and from that you are able to bill this item 731. Now, the recommended frequency of this is every 6 months, or earlier is clinically required. So this is an example where you can do it more often if, for example, the patient then develops another comorbidity or another condition, or a significant deterioration in their one of their conditions that's already in existence. It can be supported by a practice nurse or an Aboriginal health worker or anyone else, health professional working with you in the care of those facility patients. It is definitely, from a monetary point of view, worth making sure that you have some sort of a system where you are, looking at that care plan and claiming this item on a regular basis. This item 731 is also the one that triggers those patients to be able to access the 5 allied health rebatable visits, like your standard general practice patients where they need the GP management plan and a team care arrangement. For those in a residential aged care facility, you just need to have claimed a 731 in order to be able to do an allied health referral. As I've already mentioned, who can assist? It is quite acceptable, and I know that I'm sure all of you saw a lot in the medical press towards the end of last year where Medicare decided to, not let us allow some of the time of the practice nurse towards the health assessments, and there was a lot of fuss made about that. There has been no changes with chronic disease management items in that it is perfectly acceptable, and obviously these are not done on a timed basis anyway, but it is perfectly acceptable to have, your nurse or allied health practitioner or at-the health practitioner putting together these plans, providing, that the GP does see the patient and is putting the medical content and approving the medical content that's been put in. I did get a question prior to today's webinar regarding the use of nurse-led clinics when it comes to chronic disease management. Now, this is something that, for bigger practices that have got, you've got practice nurses who are well versed in chronic disease management and the use of these Medicare items, it can make sense from an efficiency, time and monetary point of view to put together nurse-led clinics. Laura, Sonia and I here at Rural Health West are more than happy to work with you individually at a practice level on implementing nurse-led practices clinics. I have done these myself in the past when I've been working as a practice nurse, and also done a lot of work with practices helping them implement. And there are, ways of looking at your data, working out who your patients are, which doctors in the practice are keen to have their patients put onto care plans, and going about it in a more orderly fashion, I suppose. It does require dedicated time from a practice nurse. It is a little difficult to try and fit it in ad hoc to the general running in a practice if you're really trying to get all of your patients on plans. Of course, it can be done that way, but if you are interested in putting together, a more planned approach, then you're very welcome to give us a call, and we're happy to work with you for your individual circumstances. This item number I like to just put in to alert you to, because I think sometimes this one gets lost. It's not worth a huge amount of money, as you can see at the bottom of the slide. It's $12, but this is an item 10997, which has been around for a while and still remained after they removed most of the individual practice nurse item numbers. So this one has stayed in the system. So if you've got a patient that's got a GP management plan or a team care arrangement in place, then you can claim up to 5 services where the nurse can see the patient without having to see the GP. So whilst it's not a lot of money, $12 times 5 per patient per year, it is actually quite useful if you've got, for example, a practice nurse, you've got a patient who perhaps commenced on a new antihypertensive and you'd like them to come in and get their blood pressure checked. you know, daily for a few days, or you know, weekly for a few weeks, or if you just put them on to another oral hypoglycemic, for example, and you want them to be checking their BSLs more regularly, they can come in and see the nurse and have something done, as long as it's related to the chronic condition that the GP management plan is about. Okay, so if they're a diabetic, you know, it's pretty simple what you could do for them, as long as it's related to the condition that's on the plan. And yes, the thing is with this one is that the patient does not need to see the GP on that day for it to be claimed. The only issue that kind of arises, and I regularly get questions about on this one, is that it's a little bit hard to monitor how many times you've done it. So that's one not so easy issue, unless you've obviously able to search back through your billing to see how many times you've billed the item 10997, which of course is possible to do. But I do know practices who tell me that they just, you know, claim it when they think it's appropriate, and if it gets rejected, it gets rejected, and they've obviously met their limit for the patient. So probably not the best way of doing it, but a way of doing it. Okay, so now we're just going to go on and talk a little bit more about the impact and the rules and how you need to be working with the allied health services where your patient is able to be referred. They often get called the free allied health visits, which is a bit of a misnomer because they're not necessarily free. There's no requirement by that allied health practitioner to bulk bill the patients. I know a lot of them do, and it depends on your location and your relationship with that allied health practitioner and how they run their business, but there is no legal requirement that they bulk bill. So I prefer them to be called rebatable services, because it means that the patient will get a rebate from Medicare for that service, which they wouldn't otherwise have got. Now, the ones we're talking about, which are the 5 rebatable other items, 10950 to 10970, and there are obviously some other items which I will also go through in a bit more detail. So the allied health rebatable services is where you've got a GP management plan and a team care arrangement in place, or the patient has is an aged care facility and you've claimed the item 731 for them. Okay. So this is where you've put in place both of the GPMP and the TCA, and then you can refer your patient for up to 5 visits in a calendar year. So it's 5 from January to December. Okay. And you do need to use the appropriate referral form that's on the Department of Health website, and I have got the link to that at the end of the slides if you're not sure. Now on that form, when you look at it, it's basically filling in the patient details, and that's where you as the GP decide how many of those 5 and who to. So if, for example, you've got a diabetic patient and you really want them to see a dietitian, for example, then you may choose to use 2 of the 5 visits for a dietitian, and then you may choose to use 3 visits to a podiatrist. So then you would be doing 2 different referral forms, and you actually do write in the maximum number of visits that that referral is applicable for. So make sure if you're the GP filling this out, or if you're the practice nurse assisting the GP and working to fill out these referral forms, just make sure you do put in the number of services that that referral is applicable for. Because obviously it's not open-ended. There's only 5 a year, and it is up to you as GP to decide who and when and how many. Okay? Now the question that I often get in these sessions is, say for example, the patient comes in September and you do a GP management plan and a team care arrangement, and you decide to give them a referral for 5 podiatry services, because you want to use all of the 5 visits for podiatry. Now, when you write that referral form, you will then obviously be putting it into the podiatrist, and you'll be putting that eligible for 5 services. Now, being September, you may only have used 3, perhaps 1 a month. So, you know, October, November, December, that means that there's 2 left come the next calendar year. The patient doesn't need to come back and see you. They don't need to get another referral. That referral can continue over into the next year. So then they could use it for January, February, for example. But when that 5 visits has been completed on that referral form, then the patient would need to come back and see you. At that point, it would be reasonable for you to do perhaps a review of the GP management plan and the team care arrangement, because you'll have gone, you know, 4, 5, 6 months since you last put the plan in place. That's when you would then do another allied health referral form and decide whether you would continue to use those 5 for the podiatrist, or whether you would decide that you want to just maybe do 2 for the podiatrist for now, because you want to monitor the patient and see how they're going, and, you know, that's up to you. Okay. So the referral form itself continues until those services have been used, but the patient's still only eligible for 5 total between January and December, which does get a bit confusing, I agree. This slide is just showing you the list of the eligible allied health providers that have been approved by Medicare for this system. In saying that, all of these providers still need to be registered with Medicare and have a provider number, just like you as the GP does. Okay, so you do need to check if you're referring patient, for example, to an exercise physiologist or you know, an audiologist. You do need to double check that they actually are registered with Medicare as a provider. Most of them will be these days, but you do, you know, need to check and not just assume. Now, the reason that psychologist is in brackets on this list is that when these chronic disease management items first came into being with these allied health rebatable services, psychologists was included in the initial list. Since then, we've got the better access system through the MBS for mental health, where you do a mental health care plan, and then you can refer your patients to a psychologist for those rebatable visits, the 6 visits, which I'm sure you're familiar with. So Medicare say to us that they would recommend that under the chronic disease management items with the 5 visits, that you would use those for physical problems, and that if there was mental health problems coexisting, then you could do a mental health care plan and then refer to the patient to a psychologist through the better access items rather than using these items. You can use these ones in this way for a psychologist, but it's actually better for the patient if you do it through the better access mental health care plans. Now, if what I just said was double Dutch, feel free to get in touch with us, and we're more than happy to give you some more information about the mental health care plans. I'm not going to confuse the issue today and add those in. Now, this slide is showing you what the responsibility is from the allied health provider perspective. So the allied health providers have got a Medicare provider number just like you as a GP has, and again, just like you have responsibilities, so do they. Now, under their responsibilities of receiving the patient under these 5 rebatable referral visits for their chronic disease management, the allied health provider, as I said, can choose to bulk bill or private bill. You know, there may be a gap. They are required to give you a written report after the first and last service, or more often if clinically necessary. Okay, so if, for example, you decided to use those 5 visits to the podiatrist in the example I used previously, well, it's perfectly acceptable to get a written report back from the first visit and then the 5th visit. You're not required to get, the allied health provider is not required to give a report after every visit if they know they're going to be seeing the patient over a period of time for, you know, multiple appointments. However, if they're only seeing them, you know, once or twice, then they are required, under the provisions of their provider number, to give you a written report. So you're not asking them a favour to give you a report back. It is actually part of their Medicare requirements. Okay, now just talking a bit more about the collaboration requirements, because this is where everybody gets a bit confused, and this is the hard part. So the Medicare requirements say that it must be two-way communication between the GP and the providers that are contributing to the team care arrangement. So this is where we're looking at not just the allied health referrals, but we're also looking at the team care arrangement requirements. So two-way communication, preferably oral, but it can be written, including faxes or email, obviously, as I said before, noting the privacy requirements. But the contribution has to be specific to each patient. So I know that at some stages when this was sort of first introduced, there was a general, perhaps, misunderstanding that it was acceptable to say to your local physio, if I send you patients under a team care arrangement, are you happy to see them? And I can take that as a blanket agreement. Well, Medicare has been very clear at saying that that's not acceptable. Okay, so it does need to be individual and it does need to be two-way. It doesn't have to be the GP that's having that communication. It can be the practice nurse, for example. But there does have to be some feedback, recognition and agreement that they're willing to be a part of the team care arrangement, that they're willing to accept the referral for that patient, and they do have to be giving some indication of what it is that they're going to be doing for that patient. Now, obviously, for your standard allied health providers, you probably will have a good relationship with them and you will have a good idea what they're basically going to do, but you just need to try and individualise it, and it does need to be documented on the team care arrangement. For example, practice nurse X spoke with physio Y, agreed to accept a patient, plan of care will be, you know, assessment, overview, exercise plan, and will be reviewed on a weekly basis, whatever it's going to be. Okay, so it has to be specific to the patient. If you're referring to an allied health provider to use up one of the 5 visits, it's acceptable under Medicare to get agreement that they will accept the patient and a rough idea of what it is they'll do. They don't have to have seen the patient first before you can actually build the team care arrangement. So it is a bit of a grey, fuzzy system in that it's acceptable to just have agreement and a rough idea of what the provider is going to do if you're using those 5 rebatable visits. But for your other standard providers that are going to be involved in the care of the patient, for example, a specialist or allied health providers where you're not using the Medicare rebatable items, it is considered by Medicare that you should be getting a clear idea of what it is that they're going to do for the patient, preferably that they've already even seen the patient. That's pretty simple to do when you've got the patient who's already been seeing that endocrinologist every time he visits town, every 6 months, or, you know, other visiting specialists and other perhaps allied health provider that have been provided through a hospital clinic system, for example, through WACS, where the patient, or, you know, one of the services that have been provided where the patient's not actually paying for the service. you will already have information where you've got a letter back saying, you know, seen the patient so-and-so day and this is the plan and no change in treatment or whatever it is. So if you've got all of that in the system already, then you can obviously use that information. But if you've got a new patient with new providers, it's not considered appropriate by Medicare to claim the team care arrangement until they've actually seen that patient and given you a treatment plan, which is a bit of a pest when you're in a rural area and your patients are having to travel a long way. I do understand that. So that does require you to be a little bit creative, and perhaps where you want to be talking to those providers or getting your nurse to talk to those providers about what's likely to happen. Now this slide is just to give you a bit of information about another group of items that are available for your type 2 diabetic patients. Now these item numbers are not used much in the system, so I believe that either people think they're too hard or they don't have the services available or they're just really not sure that they even exist. So for your patients who have got type 2 diabetes, who have got a GP management plan, or your aged care facility patients where you've done a 731, you can give them a referral to access 1 assessment visit and 8 group services per calendar year to either or a diabetes educator, a dietitian or an exercise physiologist. So these are really good item numbers for your type 2 diabetic patients where you've only got a GP management plan in place, you don't have a team care arrangement because they're reasonably stable, you're managing the patient quite well yourself, but you would like them to occasionally or you know, have the benefit of a diabetes educator or a dietitian. This actually means you can refer them for an assessment visit once a year and up to 8 group services if they are available, obviously, in your area. So yeah, if you want any more information about these ones, again, you know, we're happy to provide that. As I said, you know, they're not used greatly, but I think, you know, there are lots of patients who could benefit from, you know, just a one-off assessment with a dietitian just to get them back on track, you know, or a diabetes educator. And you don't have to have a team care arrangement in place for this one, so it is a good one. Okay, well, I'm just looking at the time. We're doing pretty okay. I just wanted to talk a little bit now about how you actually put these into practice. Now, most of the medical software, clinical software programs have got their own templates built into them. So, for example, Best Practice Medical Director, most of them have their own templates in there, which of course, if you're using them and you're comfortable with them and you're happy with them, that's fine. But there are some websites that I've got on this slide here where you can actually go in and have a look and get some specific templates. Now, the 2 bottom dot points on this slide here, the NEVDGP and the ISML.org one, both of those websites are organisations that were out of the old divisions of general practice, but have kept a lot of their chronic disease management care plan information. They've got some really good information. They have the cheat sheet on how to download and put these into your system, and they are pretty simple to do, and they give you a step-by-step direction depending on what your software program is. And you can get some of the templates which are sort of the pre-filled ones. So for example, a diabetes care plan where it already has listed off what, you know, the common problems are. The idea with these templates is that you then individualize it to the patient. So it's not good enough to just download it and sign it and be done with it. You do need to individualize it. So obviously when you get to the HbA1c, if your patients HbA1c is 14, then yes, your ultimate goal might be to get it to 7, but realistically the next goal for that patient might be to get it to 11. So that's the information you need to put it in, so that when the patient's looking at it, they go, well, my HbA1c is 14, I need to be aiming to get it lower than that, you know, in the next 3 to 6 months when I'm going to be reviewed. The ideal is 7, which then highlights to the patient they've got a fair bit of work to do, but you're not trying to tell them that they've got to go from 14 to 7 in 6 months, because that can be a little bit daunting and off-putting. The same, for example, with a patient with hypertension. You know, you might not necessarily be going for 130 on 80 in the next visit, but give them a reasonable goal. And then, you know, I do find with patients that if they've actually got, you know, a piece of paper with numbers on it that they can aim for, they will get a bit more interested. And it's always good to make sure then they know what their blood pressure was every time they've had a visit, so that they can compare themselves and know how they're going. So the idea is to individualise it. So these pre-filled templates, for example, they've got alcohol, smoking, physical activity, all those things put into them. If the patient's a non-smoker, you might just want to delete the whole row. So you would just take it out. So the idea is it's quite okay to use these pre-filled templates, which do help you. It makes it quicker. It gives a really good final plan for the patient, which is covering off on, you know, lots of areas of their health. But yes, just make sure that you do individualise it. And for some people, you know, you might prefer to do free typing. So you might actually prefer to have a template which is quite blank. And there are definitely templates available that are like that. So yeah, so if you're looking for anything specific, again, you're very welcome to get in touch with us, and we will give you some examples of some that might suit you. This slide here is just giving you all of the links to all of this information that I've been talking about today. So that first dot point, which is the Department of Health, where it's health.gov.au/MBS primary care items, that is actually a really, really good website. And that is where, when you click on there, it will list off all of the different components. Like that's where the health assessment stuff is, the Aboriginal specific items, the chronic disease management items, you know, the 4-year-old healthy kids checks, all of those things, where they actually give you really good information about what it is that they're expecting you to do for those items. And it is a really, they're easy to read and quite well written. For the forms for the allied health referrals is under that next link. The MBS Online, I hope that you're all very, very familiar with the MBS Online. They've just had a bit of a change to that website recently, and you need to click up on the right-hand side now to do the search. And you can either search by number alone or number and content. If obviously you know the number, it's much easier to do it that way. You put the number into the box, press enter, and then at the bottom of the screen will come up the explanatory text of what it is that you're required under Medicare to do as a minimum to meet the requirements for that item number. And it also has the dollar value and that sort of thing. And the next one there is the online e-learning. That's for new health professionals, so people who are new to the system and new to Medicare. That is a free online training program on how to understand and work with the MBS. So if you are new, then that's a very good one to do. And then, of course, there's the inquiry line at the bottom for you. So I think we've actually come to the end, and we're about 5 minutes before 2, and I'm sure you've all got patients waiting. So I hope you've enjoyed today's session and found it useful. If you would like any more information, then please get in touch with us. Otherwise, I will say thank you very much to all of you for joining in, and goodbye for now.